Welcome to the Health Innovation Summit. The session will start in 5 minutes. Please take your seats and silence your electronic devices. Welcome to the Health Innovation Summit. The session will start in 5 minutes. Please take your seats and silence your electronic devices. Welcome to the Health Innovation Summit. The session is about to begin. Please take your seats and silence your electronic devices.
When there's a great scientific discovery, it's not one moment that defied possibility or one point that changed everything. It's many. A miraculous breakthrough only comes by risking failure over and over. Increasing our potential to improve patients' lives means we never settle. Transforming the practice of medicine demands going all in on artificial intelligence. Every day, our team rises to the challenge to pursue what once seemed impossible, to lead innovation in clinical trials, and to break down barriers for those who need it most. These moments may seem small, but to our patients and their families, these moments are immeasurable.
MCG Health, part of the Hearst Health Network, is a healthcare industry leader in evidence-based clinical decision support technology. MCG solutions cover the entire healthcare journey and can be integrated with virtually any electronic medical record or medical management platform for a seamless workflow. MCG is currently used by thousands of hospitals, a majority of U.S. health plans, and is widely trusted as a common clinical language by payers, providers, and government agencies. Learn more about how MCG can help support quality and efficiency in healthcare decision-making at mcg.com.
Please welcome the president of NCQA, Peggy O'Kane.
Good morning. How's everybody doing? Hanging in there? It's a pretty busy few days, and I know you just walked about 2 miles from the quality conversations, but it's good for our health. Let's remember that. So I just want to recognize what an amazing meeting this has been, and I think that, the quality of the speakers is so great, so I want to congratulate the speakers, and we have a fantastic panel coming up right after us. But also our team, it's a competitive process to get to present at this, and I think they've done an excellent job. And I want to make sure you're all going to give us your feedback about whether this is the right level, what should we be thinking about differently. But we're going to have a little introduction of Michelle Schreiber. And we were just talking, and we both wore a little Halloween. You saw my hat maybe yesterday. And she had some fascinator thing on her head. But we decided we could have been kindred quality spirits yesterday. Because now she came on a very different path from Henry Ford Health System and Health Alliance Plan, which is the Associated Health Plan. And she was getting data for HEDIS out of the EMRs of the hospital, out of the hospital system. So she was an early pioneer in this. And she came to CMS with the mission to make this work. And we both agree that quality measurement is a very important thing to get right so that people that are actually doing the work don't feel burdened by it. And we know we're not there yet, but so she has been doing her part on the CMS side with a lot of other great people at CMS, and we've been doing our part to try to get to a point. Our goal is to have measures flow from delivering care digitally. So we know that's not simple, but we're very excited about it. So Michelle is both the Deputy Director of Quality at the Center for Clinical Standards and Director of the Quality Measurement and Value-Based Incentives Group at CMS. She also co-authored the CMS Universal Foundation to Align Quality Measures paper that was in the New England Journal. And really the point of that is, if we're all measuring things differently, what hits the providers, the practitioners at the front line, is chaos. And it's one of the reasons that quality measurement is burdensome. So we are doing our part to try to align. They are doing their part. And there is a great appetite there to have the non-invented here reaction to quality measures. So it's a big job, but she's an incredible leader. And we just thought we'd have her share some of her thoughts here. And then I want to put in a plug. We're doing a Meet the Experts session at 10 o'clock in the Tennessee Ballroom, one of the Tennessee ballrooms. So I'm really looking forward to day 2. It's really hard to choose when you look in that app. There are so many great sessions. I hope you have a wonderful time. And thank you to all of you who've been coming up and talking to me, because meeting you is a great, wonderful privilege for me. So thank you so much. And please welcome Michelle Schreiber, Dr. Michelle Schreiber.
Ooh, those lights are bright. Good morning, everybody. There we go, a little enthusiasm here today. I am so excited to be here, really, and thank you to NCQA for the opportunity to be here and to be part of welcoming you to day 2 as we consider together future strategies for quality, quality measurement, innovation, digitization, interoperability, and other creative ideas on how we can improve healthcare quality, equity, and value. You know, we all recognize the following that I'm going to say, that despite advances in healthcare quality over the years, we remain the country that spends the most on healthcare, but has some of the lowest quality performance, such as life expectancy or chronic disease outcomes. We have notable equity gaps, such as in maternal care. And patients still experience harm far too often, with studies showing 1 in 4 Medicare beneficiaries experience harm. We also know that during COVID, our quality performance really worsened. In part, and there are obviously many reasons for that, but in part because our systems to support quality really weren't resilient. So we must do better as a nation. And to improve, we need to study performance. And for that, we need science and we need measurement. That's why this conference is so important, devoting our time to healthcare and quality innovation. NCQA has been a leader in healthcare quality measurement for over 35 years. They really put it on the map. CMS uses many NCQA measures across our multiple programs, and NCQA measures are the foundation of our universal foundation. In other words, those key core measures that we're trying to drive across all of our programs and really solidify all payers around. We share a common vision of advancing quality through measurement and learning. And we share a commitment to improving measures through alignment across all stakeholders. That was part of the point of the Universal Foundation. On focusing on high priority, meaningful and impactful topics such as maternal care. Reducing the burden of reporting. Integrating measures into the learning health system, so it's really a seamless, continuous flow of information to clinical workflow, to the outflow of data, all in a learning environment so that we can have rapid action. And with this, we aim to ensure that all individuals can achieve their optimal care. And of course, we're looking to drive value. Better quality care, safer care, more equitable care, but with reduced cost. We also share a common vision that we need to transition to a future of a fully digital ecosystem of measurement in order to achieve these goals. Like all other industries, healthcare is and will transform through digital data. Digital interoperable data is the foundation of healthcare's future. There are so many benefits to this transition that it's actually almost inconceivable that we can go in any other direction. Digital measures allow insights that capitalize on the robust clinical information to be found in the electronic medical records that, by the way, we spent $35 billion encouraging people to use. Once implemented, and I recognize that caveat, once implemented, digital measures are far less costly, the Hopkins study demonstrating that a few months ago, and less burdensome, and they can become a natural output of clinical workflow. Care is improved by having all available data, regardless of where the patient was seen, and enabling digital mechanisms of safety, such as barcode medication administration or immediate clinical decision support. Data is democratized, with consumers having open access to their information. Queries can be done in real time to accelerate rapid action. And digital data allows for care everywhere, in any location with telemedicine. And of course, only digital data is going to allow us to layer on advanced analytics and eventually AI tools. Not eventually, that's happening already. I don't think there's anyone in healthcare that wants us to go back, not to paper charts or just claims-based information. In a way, that's like asking us to give up our cell phones. Nobody wants to go back. So we need to push forward together. That's not to say that this transformation is easy, because it's not. Data remains hard to get, and it's not always standardized, which leads to poor data quality in some instances. Digital transformation means workflow change, which means work, which means change. Two things not always popular. And it requires a new paradigm of payer to provider to patient and back again, communication and transparency. Data security must be ensured. We've all seen examples of that in our recent lives. It is painstaking, complex work. But I know that NCQA is committed to this digital future and assisting organizations in being successful. So too are many government agencies, such as the Assistant Secretary for Technology and Policy, formerly known as ONC, CMS, CDC, the Centers of Disease Control, the FDA, Food and Drug Administration. All of us are on journeys of transforming healthcare through digital innovation, using FHIR for healthcare data exchange, promoting interoperability, such as through trusted exchanges, utilizing advanced analytics, and ultimately AI to make better decisions, including better decisions about measurement. We recognize that we must all learn this together. We know this requires flexibilities of time, learning, and support. The good news is that there are really helpful signs that we are all making progress. You heard yesterday, NCQA's recent analysis shows a significant increase in reporting non-claims digital data, and that plans that used electronic non-claims data performed better. I will say at CMS, we are beginning to see similar trends. In addition, I'm pleased to say that we are working jointly, the government and NCQA, with others in public-private partnerships in the digital quality implementer community to advance digital technology and really try and understand the barriers and come up with solutions. The other good news is that electronic medical records are actually becoming easier to use, with easier data capture through tools such as voice recognition and better clinical decision support. Some of you may have been here in Nashville at the Oracle meeting just a few days ago. There are a lot of advances there at Epic and in other electronic medical records to really make it easier to do this work. Patients, too, are getting involved. Increasingly, they are accessing their data through patient portals and coming to understand and ask questions through it and getting patient education. Some states have robust health insurance exchanges to share data, and it's leading to better care. And more organizations are joining a national trusted exchange. I think we're actually approaching the tipping point for digital acceptance. The future is looking hopeful through innovation and transformation, through collaboration. Thank you all for being part of this journey, and thank you to NCQA for leading the way. I hope you enjoy the rest of the conference. Thank you very much for being here.
Good morning. The moderator of our morning panel set the standard at NCQA for how to lead on health equity. As Director of Health Equity Initiatives, Brian Buckley quickly made his mark as the person everybody at our company wants in their meetings. And that's because he stands out as that savvy collaborator who has great ideas and knows how to make things happen. Brian is now Director or Head of Public Health at Care First Blue Cross Blue Shield, where he remains a resource and an inspiration to many of us at NCQA. And I do mean inspiration because, and you can take this as a sort of warning, if you connect with Brian on LinkedIn, you will soon conclude from his frequent postings that you are the most untraveled hermit on the planet. He is at every conference you ever wanted to attend, and he knows everybody. Please welcome, along with this panel, Brian Buckley.
Good morning, everybody. See, that wasn't enough energy. I come from a call and response culture. Good morning, everybody. There we go. Well, hello and welcome to our keynote Equity Trailblazer session panel, Equity Across the Care Continuum. Andy, I think, did a really good introduction to me on where I'm at now. But just to repeat, Head of Public Health at Care First Blue Cross Blue Shield, where I lead our equity strategy and our public health partnerships. But as he also mentioned, I am also a super proud NCQA alum. As I was leading a lot of health equity things, and one thing I was talking to a couple of folks earlier, once you become part of the NCQA family, they don't let you go. So, because we know this is a collective effort, and I know there's so many NCQA alum out there on in the room. So, one of the most vital things that I learned at NCQA was really the mantra, there's no quality without equity. And I've definitely taken this forward in my new role at Care First. And so I'm honored to moderate this incredible session joined by a group of visionary leaders to navigate this journey. To my left, your right, we have Dr. Camille Burnett at the Institute for Healthcare Improvement, IHI. We have Tosan Boyo at Sutter Health, Dr. LaShawn McIver with AHIP, and Daniel Dawes from the School of Global Health at Meharry Medical College. So I'm going to do a little preamble to get us started here as we go on this journey here together. So for those that know me well, I'm really big about my birthday. If anyone has followed me on LinkedIn, I think Andy already said it, I'm really big about my birthday in July. And every year on my birthday, I really have like it starts my new year off, and so I don't really like to get bogged down by everyone's January goals here. And so last year, you might remember I was on the same stage talking about fatherhood, and fatherhood was my theme last year, and really welcoming myself into parenthood, and really this idea that I talked about last year around future people, and how it's so important for us to think about the work, that there are more future people than current people and past people that have ever existed. So this work requires our collective action and really building the building blocks for the next generation. This year, this July, my theme for this birthday year is Good Trouble. And this was inspired by the time we are in right now as we think about the next phase of health equity. I think we can all agree in this room, we have all heard the term health equity quite a lot. Even as we were going to the expo, we know health equity is being thought of by vendors, by healthcare delivery, by health plans, even by our federal government. So it's all around. And at the same time, we also have to be clear, we also feel the resistance to transformation of our healthcare systems to be equitable for every single one, no matter their background and location. So we're in Nashville, we're in Tennessee, so you can't leave out here without a great John Lewis quote here. As the great John Lewis said, "Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It's the struggle of a lifetime. Never be afraid to make some noise and get into some good trouble, necessary trouble." And we know the work that we do here in health equity, it's necessary trouble for the future generation of our country and our world. So I look at my esteemed panel. I'm excited to get into a conversation about this, on where we're at right now, and where we need to go for the future. So let's get into it. So let's start by talking about where we are today. Our health equity has come a long way, but we know that there's still a lot of work to be done, and there's a lot of gaps in care delivery and access. So as a general for this section, we're going to talk about what are the key gaps around health equity across the care continuum today. So, and how is it impacting care? So I'm going to start with my wonderful friend, Tosan. From your perspective on the front lines, how are health systems addressing these challenges, and where are we still falling short?
Appreciate that, Brian. And Brian was right. Once you become part of NCQA, they don't let you go. Yeah, and shout out to Andy. So for me, my theme right now is really focused on how do we move health equity from activity to productivity. It's now become a theme that everyone talks about, health equity. People believe they understand it. People are constantly hearing about it. But in the delivery system, in my world, at Sutter Health, we have about 24 hospitals across Northern California. We take care of about 3.5 million lives. And in my role, I lead the East Bay division. The reason why that's important is when you come to a delivery system, in many cases, our patients have already experienced multiple things by the time they show up to the ED or they show up to primary care. And then the question becomes, how are we taking care of patients when they present? How are we acknowledging their story? How are we making sure that we're ensuring that the unique experience is tailored to them, and understanding that, hey, language, ethnicity, sexual orientation, gender identity, those things are important, but then I don't want health systems to start losing the thread as to, oh, we talk about it, therefore it's happening, right? So how do we go from we talk about it, we've started tracking data, to we want to start closing gaps? So my mission right now is how do we move from activity to productivity, and that starts with how complete is the data that we're collecting across acute care, ambulatory care, and then after that, what theses are you developing in your department, in the health systems, about what gaps you want to close? If you're in ambulatory care, how are you ensuring that your third next available appointment is equitable across race, ethnicity, and language? If you are in the ED, what is your thesis on left without being seen? Because you want to make sure that patients who aren't waiting end up leaving. If you're in rehab, what are you doing to ensure that language access and people presenting their pain is happening in an equitable way? So to Brian's point, we've talked about health equity quite a bit in the past 5 years, and I think it's time for delivery systems to start saying, okay, what gaps are we closing? How are we holding ourselves accountable as it relates to our quality metrics so that we can be productive? And then the last thing I'd say is we have to accept that health equity doesn't end. There's this idea of like, okay, at some point it's no longer going to be trendy, but we don't stop doing quality work. So we have to accept that health equity work is never going to end. It is fundamentally how we validate and verify that we're actually improving quality. And that's where I believe we have to start moving towards.
Thanks for that. You mentioned something around this idea of accountability, and in many ways, our leaders are the ones that are keeping the organizations accountable. So I'm going to shift to you, Camille. What are the current leadership challenges when it comes to embedding health equity into the core operations of healthcare?
Great. Thank you so much, Brian, and thank you everyone for being here at NCQA for hosting this wonderful panel. I'm going to start by explaining a little bit about some of the work that we do at IHI and specifically related to the space of health equity. So IHI is a global organization. We do a lot of work in terms of quality improvement, system resilience, health equity, and patient safety. And relating to health equity, part of that work that I have the privilege to oversee, we work with a lot of different actors across the healthcare ecosystem. So we hear from those in the healthcare system side, we hear from those in the payer, pharmaceutical, biotech research, and as well from individual practitioners, professional society members. And as a result, we are hearing some synthesis of similar challenges from all of those different actors in the healthcare system. Primarily, we hear a lot about high expectations. There's often high expectations placed on individuals who oversee this work or for individuals to do this work, and often those expectations are not aligned with the amount of time that's allocated to do that work. In addition to right-sizing expectations, there's also the need to have sufficiency of resources, whether that's time, whether that's money, whether that's people, enough people to deliver. And we know with the proliferation of those who lead this work, oftentimes they're an entity of one. They might be the first person in those roles. They may not have an office of individuals doing that role. And maybe sometimes that office is siloed. So it happens to be apart from the inner operations of the system at large. So there's challenges in sort of threading and connecting all those pieces, because once it's been siloed, it's very hard for other people to see themselves in that work as part of their responsibility versus it belonging to an office. Another challenge we hear is also getting people, the difficulty of getting people the buy-in, getting others on board with doing that work. And that could be from the leadership level, that could be from the board level, and that could also be just across the organization, really making that work visible and making the case for why that work matters. And we do hear about the realities of, challenges of not making a moral case. I think people are in their heart convinced that this is a good thing to do. However, the business case in terms of the numbers and the sense and why it is so important beyond improving lives and what is that return on the investment at large, not just for society, but for the organization. So they do have challenges in making those connections. We've heard about data earlier today, and as well, Tosan also mentioned that data collection is important. And so having access to that data, being able to have the right types of data so that you can stratify that data, and then that data can guide you towards solutions that start to close those equity gaps is important. So some systems do struggle with getting access to the right types of data and how that data is collected, et cetera. And then finally, I'll touch on the context that we are in within this country, within some of our states, where even using the word health equity is challenged. So we work with some systems and specifically health equity leaders around helping them to reframe that languaging and reframing those narratives so that they're still able to do the work. However, in some cases, it could be challenging to be able to move completely into health equity space without being able to say, this is the type of work you're doing. So that's some of the challenges we hear that impact their ability to be successful in the role or to be able to successfully do that work.
Yeah, thank you for that. It was actually a good segue as one of my favorite quotes that folks have heard me talk about is with Deming, every system is perfectly designed to get the results it gets. And
absolutely.
That really speaks to, you mentioned and alluding, that a lot of states, and we're in November, a big election, there's a lot of aspects around the policies and procedures, and I know we're gonna shift to you, Daniel, here. You've done a lot of your work in this space, so can you talk about the current political and judicial landscape that's affecting the ability for us to address health equity?
Absolutely, and good morning, everyone. So I'm really glad that you set that up because my work has focused on the political determinants of health. We view these as the fundamental causes, the drivers, the instigators of the health inequities that we're tackling downstream, both midstream and downstream. And so let me focus quickly on the judicial branch because I think that's been a very interesting development among all three branches of government, and the impact that they're having in terms of our ability to move the needle. So recent Supreme Court decisions have shown a movement towards the devaluation of scientific expertise, of evidence, and so forth, among a range of issues. And I think that movement that we see from the Supreme Court is connecting into that larger anti-science, anti-intellectual wave that we've also, or anti-evidence wave that we've also seen at the political, in the political sphere. So for me, one way to look at this is to look at how the Supreme Court's movement has basically led to undermining and usurping power from the elected branches of our government. You can see this throughout, and you can see how there is a usurpation of power from agency heads, from agency experts at the Department of Health and Human Services, and of course, other administrative agencies. And let me tie it quickly, since we're talking about health equity in particular. What I have been following over the last 8 years, since Section 1557, for instance, of the ACA came out, the rules for that very comprehensive civil rights agenda came out in the Affordable Care Act. What we have been doing 3 years now, 3 times over the last 8 years, we have seen the introduction of regulations to expand and to really push our knowledge on these issues, to expand the umbrella of inclusivity and equity in healthcare. And yet opponents have tried their best to use litigation to undermine that rule. Right now, the Biden administration came out with an even more comprehensive rule, and I'm curious to see how, with the Loper decision, how that will impact, giving the right again to from administrative agencies back into the courts, where they are retaining that power. I'm curious to see how judges will interpret that rule moving forward, and how that might impact our ability to achieve equity and quality.
I love how you said that, and especially just going, one of the things and now working at a health plan, you know, there's this idea when I hear like the mind is strong, and I think everyone wants to do the right thing, but the body can be kind of weak on actually reacting to this work. And so there are a lot of challenges that people are looking at, both from the leadership level, frontline level on healthcare delivery, but then the political landscape on how far can I go. So LaShawn, I'm gonna switch to your perspective. What are the challenges that health plans have around advancing this work?
Well, thank you for that question, and good morning to everyone. You know, as I think about where we are, so our current state, we actually are all facing similar challenges. I think you've heard from a leadership perspective, from a systems perspective. Likewise, with plans, we all are experiencing the same types of challenges. So in my role at AHIP, we represent the private health insurance industry, so our plans provide services and coverage for millions of Americans. You know, this past year, this has been my first year in this role, I've spent a lot of time talking with the equity leaders across our system, trying to understand what are the areas of opportunity, our challenges, and all of those things. And so, you know, we are all on the same continuum towards achieving equity, which is our ideal state. And so we've already said that is a journey. You know, our plans, individually, I've seen some incredible efforts that our plans are doing to advance health equity. And what we're focusing on at the moment is what are the things that as an industry we need to do to have collective progress industry-wide. And so some of the things you've heard, things around data, things around what are we doing with the learnings that we have to improve the lives of those that we're covering, and then also how are we using the lived experiences of those that our plans cover to improve that work. We all have the same grade, unfortunately, when it comes to healthcare and health inequities. With the recent Ending Unequal Treatment report, we've had 20 years to do something about data that we knew 20 years ago. And so currently, we are all still evolving. And what I'm most excited about the current state is we are finally starting to deal with some of the systemic barriers that have prevented us in the past from moving the needle. And so this is an inflection point. This current moment is an inflection point. And as was mentioned, this work is harder in some parts of the country. It's harder, arguably, in all parts of the country. And we know with the political outcome, there may be additional challenges to this work, but the people that we are all treating collectively in our industries, they're not going anywhere.
Yeah.
So we have to take advantage of this inflection point of the system-wide changes that we're seeing from whichever industry you're sitting in as we continue to do this work. So I'm actually very excited to see the progress we have made from a health plan perspective, and I'm looking forward to this journey that we're on together to advance health equity.
Thank you, LaShawn. As you mentioned, and as we all have kind of alluded to, this is a journey. And it can be hard. I think for folks that were here last year, we talked about this work can be really, really hard. I often tell my team, some of them are here, they often hear me say around health equity, it's like ice skating uphill. And so we got to get them strong thighs working. We know there's a lot of resistance to this work. So as we kind of think about this bridge aspect, we guys all alluded to the current state of where we're at. But now we're on this journey, crossing the bridge, and we know there's a lot of gaps, there's a lot of traps to some degree as we try to get to this future state. And really think about what an equitable future is. So Daniel, I'm going to come back to you here. There's a lot of resistance to health equity efforts in today's political climate. I think if you just turn on the news, you hear it, you see articles about it. How do we manage that resistance while keeping focus on the real health outcomes at stake?
Another great question. So I think it's about staying motivated, right? It's easy to get into that mode of helplessness and hopelessness from apathy, but I think we got to stay motivated, stay focused, and of course, stay innovative. And one of the things that I wanted to touch upon, and I'm glad LaShawn mentioned this, in terms of this being a journey as well, and in terms of causing good trouble, this is not the first time that we have seen retrenchment and regression. We have seen this, in fact, several times across the history of our country. And the way that I slice and dice history, I look at it in terms of 4 awakenings around health equity in the United States. The first occurred during the Abraham Lincoln administration, where they tried to pass the most comprehensive health reform law, and they did so, only to have opponents then come and undermine it 7 years later. We had that retrenchment period afterwards. The second awakening happened after that, about 2 years into the civil rights movement, after Dr. King had made the statement that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And health equity leaders said, Dr. King is right. We've got to address the overt forms of discrimination in healthcare. And so they did, right? Through the passage of Medicare, Medicaid, Civil Rights Act, Voting Rights Act, all of these egalitarian policies. After that, we had a slight retrenchment period. The third awakening happens, and folks said, we address the overt forms of discrimination, and yet we still see striking disparities in healthcare and in health status. What is going on? They work on that. Again, we had a retrenchment. Now we're in that fourth awakening where, LaShawn, I was so glad when you talked about the structural level. We, at all levels of government, whether you're at municipal, state, federal levels, and of course that's not true for every state or municipal government, but for the most part, we are seeing traction where we're allowed to address this issue, to center health equity to a degree that we've not been able to do before, and to make sure that we go to that structural level to develop the interventions that we know work. In some of the work that we did, for the Ending Unequal Treatment report, they had commissioned us to look at the interventions over the last 20 years, whether they were successful or unsuccessful. And my team and I found that the majority of them were unsuccessful. They had failed to take an equity lens. Many of them had failed to design them in concert with the community, to make them community designed, community-led, community-centric. And most of them failed to connect or bridge the clinical interventions with a structural level intervention. So I guess my bottom line here is that it's not the first time we've seen this, and I believe that we now have an opportunity to go even further than we have, and we have to stay motivated, we have to stay focused, we have to stay innovative.
Thanks you there, Daniel. And you talked about, and kind of alluding to my theme, my preamble about good trouble. We know this good trouble is not just something that we do in isolation, but it takes a team. And for those that have heard me talk, I talk about the Justice League, which I'm happy to see some superheroes here on the stage here with me. But this requires collective effort and coalition building across the health continuum. And so, LaShawn, you talked about earlier how you've been talking with different health equity officers as kind of building that Justice League and hearing their thoughts. So could you tell me a little bit about how coalition building can help us overcome some of these challenges, and any insight that you have around those unified voices and how we can push through the resistance.
So I'm going to pause on the word resistance. I think we just have to be comfortable with being uncomfortable, that there will likely be resistance to this work. Daniel's talked about the 4 phases of what we're experiencing. But in order to be successful in advancing health equity, it is a team sport. And so this room represents many different aspects of the healthcare system. We had a wonderful pre-conference health equity session yesterday where health equity leaders in the quality space came together, and their chief health equity officers and those leading that work. We talked about what does it take, what do you need in this moment to do what you're doing? And the coalition building, when we hear that word, sometimes we think externally, we need to bring all of these different people together, but a coalition at its heart is an alliance. It is an alliance. And so within our organizations, building coalitions and alliances within your organization is critical to the forward movement of the continued movement of this work. In this stage of my career, I have described my purpose as bridging healthcare across the healthcare system. Previously, I was at CMS as the director of the Office of Community Health, and I was tasked with bridging equity across 26 offices and centers within the federal government, within our specific agency. That could not have happened without building those alliances within our organization. Now, it's not just the people within your organization, though. Once you sort of build those alliances and partnerships, you have to understand who are the voices that are missing. And so something I've also said over the years is that we have to start looking around our rooms and seeing who's missing. Who should be in this room right now that should be a part of this conversation. What I am happy to say is I'm starting to see more and more new faces, and that is a part of the transformation that's needed to help us overcome resistance in these particular areas.
I love that. So I haven't talked to the panel about what I'm about to do here, but just a quick raise of hands. How many of you are in the quality work? Raise your hands high, raise your hands high. Okay, keep your hands raised, okay? How many people are in the health equity work? See, I saw some hands go down, and did you not hear what I said in the early part? There can be no quality without equity. So all of you that are doing that quality work, you are also doing equity work as well. You're part of that conversation. Don't just think, hey, I have my quality measures I have to think, but you're also part of the solution. And kind of going on LaShawn's point, this is coalition work that requires our collective effort. It's not any one person, it's not any one health equity leader's job, but it requires all of us to be engaged. So Tassan, as we think about that aspect, often, even in the work that I was doing with healthcare delivery and in some past work, sometimes you hear people say about this idea of check the box sometimes around health equity work. So what are some key strategies that health systems can use to make sure that we're not just doing the bare minimum when it comes to equity, but you mentioned it earlier, turn that activity into real productivity?
Yeah. First thing that comes to mind for me is in health systems, we want to ensure every single department that already has a priority metric, we should stratify it and say, what are you trying to solve? So as I mentioned earlier, if you're in the emergency department, every emergency department is tracking left without being seen. Let's stratify it. What does the data tell us? And then say, how do we close those gaps, right? And then once we start looking at that, I'll share an example. When I was the CEO for San Francisco General, our EVS department, Environmental Services, Housekeeping, was like, well, what are we going to track as it relates to health equity? And when we sat down with the team, they said, you know what, let's really think about where we're recruiting from. And then they started coming up with apprenticeships and pipelines to try and start recruiting from the neighborhoods and the community to reflect the populations that they were taking care of. And then I'll never forget, after that, they were like, oh my gosh, we're seeing a lot of progress at this. And then we want to start looking at turnover times for the rooms, which are also tied to hospital throughput. And then they wanted to make sure that there was no discrepancy in the types of patients and the turnaround time to make sure that throughput was not going to be impacted. So from my lens as a CEO, I always want to ensure that every operational metric, we want to have an equity lens on all of it to say, what are we doing differently? And the same thing applies to supply chain, right? In supply chain, you want to say, so where are we sourcing from? Who are we contracting with? What types of organizations? Because fundamentally, the more we start trying to put equity in a box, the more we are going to be enabling the resistance that we're finding. And this is my thesis right now also in healthcare is we just need to find a way to make it very clear that what we are doing is fundamentally about morbidity and mortality. It is very different when you go anywhere in the US and you're saying like, hey, our work is to ensure that no population is dying or getting sicker than the other. That automatically removes politics from it because no health system where you want to say, listen, we want to make sure no one is dying or getting sicker than at a higher rate than anywhere else. And when you come from that space, it fundamentally changes the conversation. And then it puts the impetus on the operators to say, okay, we don't want to just keep watching metrics. What are we going to start doing to close the gaps? And I'm at the point now where I feel like we've spent a lot of time as a health system in the US focusing on the data. Joint Commission is on board, CMS is on board. Now we need to start doing PDSAs. That's what quality is fundamentally about. What are the PDSA cycles that we're going to be doing about health equity in every department? Everyone here knows what a PDSA is. So let's look at hypertension and how do we want to ensure that if you're Black or African American, where you have a genetic predisposition to hypertension, that we want to make sure we're closing those gaps. Hemoglobin A1C greater than 8. What are we doing to make sure that the diabetes is not, we're not seeing like a higher incident rate with a population compared to others? That's where we need to start moving. And when I think, going back to this theme about resistance, it's becoming a thing. We do not want just the one person or the health equity officer or the person that is a part of their job to be talking about this. Health equity is everyone's job. Eliminating disparities is everyone's job. You want to make sure that when patients present to your hospital or clinic, their experience shouldn't be tiered. So we have to be saying that uniformly across the system. And then also tied to incentives. At our institution at Sutter Health, I'm very proud to say that everyone has a health equity metric that is tied to incentives. Like we are walking the talk. And I look forward to a day where every health plan, health system is saying, you know what? We keep talking about this and we want to tie it to compensation to show that yes, equity work is fundamentally quality work.
I love that. And you tied it up really well with the PDCA stuff because I'm going to turn it to Camille. And for those that don't know IHI's work, really fundamental and really, we know that as we try to address structural things, it requires stepwise. There's not like one big initiative. And I remember in the earlies, you know, there's a lot of people saying, we're going to solve all world's problems in 2 years. But we know this is a stepwise approach and really requires intentionality. So Camille, if you could talk about the need for structural change in organizations and how you have looked at healthcare redesign to really address equity as a core function, not just an initiative.
Absolutely. And you know, so much of the areas that I would touch on to talk about this, all of you have raised them. We know that equity is something that has to be embedded in all that we do. And I think if there is a theme that has been elevated across what all of us have said, it's that equity has to be a part of everyone's work, all that we do, et cetera, because we know that the system by design has been designed inequitably. And because of that, we have to be intentional to address our structures and our systems to make sure that it is embedded equitably. So to do that, we know that we have to be proactive in our approach. We can't just be reactive in our solutions for equity. And that means we think about equity from the beginning, to your point, Tazan, with every line of our business, every line of our work, every aspect from the point of care beyond, we think about where equity should be embedded throughout. And in addition to that, we often talk about 3 core areas that we need to focus on to make sure that we truly can redesign the system. And the first thing we need to do is we need to make sure we build the capability and the capacity to do this work. And some of that I addressed earlier when I was speaking around the knowledge, mobilizing skills, and being able to have the right resources and tools to do that work. Secondly, we also have to make sure that we change the policies, the practices, the payment systems, et cetera, to make sure that we can sustain and accelerate this work across the ecosystem. And then finally, we also have to transform. We have to transform the hearts and the minds of the individuals who are doing this work, because it is not just a policy that's doing the work, it's people. And you have to bring the humanity into the system in a way that it is able to flourish. And so to do that, you have to also change the narratives that we have related to equity, and we also have to transform the mindset so that it does become a part of people's way of being and not just their jobs.
I love that. And so now we're going to shift our conversation to this idea of the future state here. Now that we look ahead, we want a future where health equity is integrated. That's the story. That's really the outcome that we want. That we don't even, to your point, are not even thinking about health equity because it's built into the DNA. And actually, I think at the first Health Innovation Summit, my good friend Daryl Gray, he said, it has to be health equity by design that is built into the DNA of our institutions, and everyone is on board. So, but what does that future look like? And we know that it's going to have to change from where we are currently right now. And so, LaShawn, I'm going to switch to you. You mentioned earlier around how there are so many new partners to this work. And as we talked about the topic here of health equity across the care continuum, there's also more than just health plans, healthcare delivery vendors. We're also starting to learn about new partners like CBOs and the community. So can you give us some insight on how healthcare organizations can extend equity efforts beyond their internal operations into the communities that they serve?
I think community engagement is an imperative in this work. I love to hear the phrase, "Nothing about us without us." And over my career working in public health, I've had different experiences with what that means to build the trust within community to do this work. And the number one thing is, if you ask people what they need, they will tell you.
That's right.
It is up to everyone in this room to actually listen and do something about it. And so, in our respective places, we've talked about the different parts of the healthcare system. When we start to ask these questions, and as we are now in the health equity space, when we start to explore and to ask, within our organizations, what does it mean for you to do this work? When we are thinking about the voices that I mentioned that are missing in the room, it's important that we think about the people we're impacting and start having authentic engagement with communities. Over the course of my career, I've had the opportunity to just travel to different parts of the country. And it wasn't until I did some work in Alaska that I understood what we were hearing about their challenges in a whole different way. And then I began to think differently about what do we need to do from the seats that we're sitting in to fix that problem. Their loved ones are not doing well because we're not actually thinking about their specific problems. And so, community engagement is more than writing donation checks to foundations and to efforts.
Amen.
It is about engaging with communities. And the last thing I'll just share is one of the things that I thought was an indication of forward movement that is just going to transform research is some of the health equity work that NIH is doing around how they think about providing grants for research. And in one of their newer models, they select the community partner who then selects who they're going to partner with versus, for example, giving it to a research institution and letting the institution pick the community partner. The community partner now has been empowered to also think about who do they want to partner with to improve the lives of their community. So that type of transformational thinking in this space is what is needed as we're thinking about the future.
Yeah, I love that. And switching to you, Tosan, we know that the pressures are going to continue, and I know for my colleagues on the healthcare delivery side, there's always another fire that you are always having to think about.
That's why I landed this morning instead of yesterday.
Exactly. And so, like, we know that there's going to be new pressures, and you're still going to have to deal with the old pressure. So, as a CEO, and you alluded to it earlier, how do you keep equity at the forefront as that top priority for your staff?
That's a great question. So the first thing I would say is, for me, I don't have a choice. I'm Nigerian, immigrant, black male, father of a 7-year-old girl. So for me, whether I like it or not, I am an ambassador in every room that I am in. I don't find it a burden. I embrace it. But with that means that I represent 11% of the US population on a daily basis. I represent 1.2 billion people on the continent of Africa. I represent 180 million people in Nigeria, in every room that I'm in. The reason why that matters is I don't have, like, equity for me is not an opt-in.
Absolutely.
Right, I don't have a choice as to what this matters. But at the same time, it also means that I have an obligation and a responsibility to make sure that for others that it might be an opt-in for, that they understand the impacts it has on a daily basis if you view health equity as an opt-in. So part of my job as a CEO is making sure that everyone in the team, everyone in the organization fundamentally understands why this work is important. In my market in Sutter Health in the East Bay, we have the most Medicaid patients. In my career, I only choose to work in health systems that are the #1 Medicaid provider. I'm a product of that population. I care deeply about that population. I also believe Medicaid tells us the story about America. Yeah. It tells us what are the challenges. If I fundamentally believe if we make Medicaid the best platform possible, it can fundamentally change the US. Medicaid is the only US policy that touches from birth to death. It is. So I look at Medicaid as a health equity initiative. And when you approach this work from a place of it is necessary for us to be successful, it is necessary for us to show that we're having an impact, it changes the way the team functions. And I want to double down on what you said. I think health systems, we need to find a way to move away from community benefit is how we work with the community. Yep, in my current role, like, I am looking at communities so differently. I want to spend, as much as I'm looking at operations, I also want to spend a lot of time in the community. We're building a joint venture cancer center with Stanford, and it's going to be in the city of Oakland. Mm-hmm. That also means that the city of Oakland needs to be a part of this cancer center. And one of the things we're working on right now is how do we make sure that this cancer center is going to be one of the core economic drivers in the city. And again, working with the community, and this is something I'm trying to prioritize more of, is when we work with the community, how do we get more people to understand that healthcare is not just about a physician and a nurse? That we're going to have pipelines, either becoming an MA. A lot of people take for granted that healthcare has a large blue-collar workforce. There is no trauma center without plumbers. There is no trauma center without engineers. There is no, they're blue-collar workforce, and there's so many different trainings that keep a hospital running. And I think to make sure I don't lose that point is when we better partner with the communities, and then we make sure that the healthcare workforce understands that health equity is not an opt-in. It is fundamentally how we validate and verify quality. It really gets the entire organization to say, you know what? This is how we should be doing business forward.
I love that. Take marks for those that were listening there. I think that whole thread of really, sometimes we don't have the opportunity to opt in, and even building off of unequal treatments, inequities hurt us all. And I think that was what I was hearing. But we also know that that's not shared always by every single leader as well. So Camille, from a leadership, as you've done a lot of work in the health equity leadership space, how do we make sure and ensure with those leaders that it's not just this initiative for this time, but really it's something that's built into the DNA of their organization as a long-term change?
Yeah, Thank you so much for that. And again, I think it's really important that we think about, as we talk about healthcare and the system of care, that we recognize that it requires a coordination across many different partners, and many of them were named here. But I often talk about a system without walls. And when we think about healthcare, we have to recognize that to achieve health equity, we have to do it together, and we have to work with those partners that extend beyond what we consider to be our traditional system. And I think, Tozan, you've also raised that point here when you're thinking about with your new cancer center and working with the communities, you have to build those relationships. We can't parachute in with those communities and then expect that we're going to have some type of, extractive type of relationship with that community because it's convenient for us as a system to do that. So I think it's important that we establish those relationships, we establish meaningful, sustaining relationships, and we also think about those relationships and how they intersect across the system of care so that we have a continuum of care that extends beyond the walls of the healthcare system. So we're hearing from the community, and the community is driving the work that we're going to do because we're centering their voices and their needs. And in the long term, that's truly what's going to help us as a system get towards that accelerated space of health equity. We also have to make sure that we have a common North Star. So as we're working, oftentimes within our system, we work in what we say patchwork or siloed practices. So you have a discipline over here, a discipline working there, but we're not really working transdisciplinary with each other, and our practices are not working together toward a common goal. So I think better coordination, better alignment across the system and beyond that system is also truly important to make sure that we make lasting change. And we also have to make sure that this is a strategic priority, and it stays as part of a strategic priority. So it is not an initiative that has a beginning and an end. It's fundamentally threaded in not just as a value, but intentionally as a strategic priority across that organization, so that we're able to make sure that we're sustaining that work. And then many of the conditions that we talked about in terms of setting up this work to be successful, they also have to be a part of all of the solutions that we do to make sure that this is long-term and that it's sustained. But it has to be structurally sustained as well.
I love that. So Daniel, you get the last word here, as we also have talked a lot about leadership and really where everyone is sitting, but we also know that this involves us thinking about the future workforce. And you're in the education space, and so I want to hear your thoughts about the future health equity workforce, and how do we ensure that educational institutions are preparing leaders who are ready to address these challenges ahead?
Thank you, Brian. And let me just ditto all that my colleagues have said. We founded the School of Global Health, the nation's first school of global health, to actualize, operationalize, and optimize health equity. And we did it for all of the reasons that we've heard on this panel today. It's about embedding equity in our curricula, right, across programs, whether in medicine, public health, allied health, you name it. For us, it is embracing that multi-sectoral collaboration, multi-level, multidisciplinary collaboration, as we heard, absolutely critical if we're going to move the needle in the right direction. And for us, it's looking at where we are today, recognizing that we have so much more work to do. The Lancet did a global health study. I don't know if any of you saw that, right before COVID struck, and it found that by 2040, we were expected to decline 21 places in life expectancy, from 43rd to 64th in the world. This year, we're at 60th in the world. Think about it. We're supposed to be at 64th by 2040. That decline in longevity across population groups is happening much faster here in the United States. And in a study that we did, projecting out the cost of health inequities, it's a very frightening number. We project that this year we will be spending $477.5 billion. That's just on mental diseases of the brain and corresponding physical health conditions like diabetes, heart disease, obesity, HIV/AIDS, et cetera, that have been linked to mental health. Think about that. We haven't looked at the other chronic diseases, but those 5 essentially. And at the rate that we're going, we're expected by 2030 to hit the $1 trillion mark, just from health inequities and healthcare inequities. And 2040, that's 1.3 trillion almost. When you compound it, we're talking about $14 trillion or $42,000 per individual living in the United States. Because of those stats, we know there's something that needs to be done, And that's why we are working in the academic arena to make sure that the future workforce, right, is prepared to handle those pressing and complex health challenges. Because what we want to do, very quickly, is we want to show folks that complexity is a myth. When folks say, oh, health inequities, it's such a complex issue, I don't know where to get started. That's a myth. We're going to show folks how you can actualize this. And then we also want to eliminate the myth of the zero-sum game, that if you are advancing equity for one group, then another group must see a decline. That is an absolute myth, and we want to harness the power of collaboration to demonstrate that moving forward.
Love it. So as you know, we had 45 minutes, but hopefully you guys got a lot of good nuggets in there. But as we conclude, I just want to highlight a couple key points from the discussion. One, first, equity is not a one-time initiative, which I think you all have talked about. It's a continuous journey. So remember also to be kind to yourself.
Yes.
This is a continuous journey, and we're in uncharted territories. We've never lived in an equitable society, but it will take courage for each and every one of us to move forward. Second, collaboration is key, and we need to remember that this is all of our collective journey together. And then three, I love what you had said, or I think all of you guys have said, we need to make equity as part of the fabric of healthcare. And this is not an opt-in, opt-out. This is something that it affects us all. And then I will end with something as just a reminder, as I've always talked about my 4 Ps, about perspectives, process, people, and projections. As you are here at the Innovation Summit, make sure, all those people that raise their hands, make sure you're finding a new perspective. Make someone else and deputize another person as the health equity champion. You all are in this work together. Process. Make sure you go back to your institutions as you go to the other sessions. Start thinking about your process when you go back to your institutions, because we know there are also inequities baked into those processes, so start to reflect on those. And then I think it's been mentioned, people. Yeah. At the end of the day, this is about people, and even in the 45 minutes that we've been talking here, there is someone experiencing inequity. Thousands and millions of people have been experiencing inequities. So we can't make perfection be the enemy of good. We need to move forward. And then last is projection. What's the story we're going to tell of ourselves? When people look at this panel like 5 years from now, because we're all going to be immortalized on YouTube and stuff, what's the story they're going to tell about us? But I think even something what Sean said, what's the story that communities are going to say about our institutions and how we try to advance this work together? So I just want to give, for you guys to give a round of applause to San, Camille, Daniel, and LaShawn for this engaging, thought-provoking discussion. And remember, let's push forward together and also cause some good trouble. So thank you, guys.
Thank you.